In India, the reported cancer is that about in 1 lakh population, about 100 of them will get cancer.
Presence of cancer is 3 times in Western countries as opposed to India.
They live longer, so the life expectancy is longer than us. The longer you live, the more likelihood of getting cancer is there. Breast cancer is one of the commonest cancers. It is the commonest cancer in women in India outside of head and neck cancer.
How should someone think about it?
It is still a rare disease, thankfully.
What can we do to prevent?
Possibly modify your lifestyle to reduce the risk of cancer.
Vaping is starting to become very popular.
It is not a safe alternative. The safer alternative is to quit smoking.
What's the relation between sugar and cancer?
If you remove sugar from the diet, it will take it from the body.
Do you see any difference in how men and women respond to cancer treatment?
Men can also get breast cancer, which we don't really think much about it. When that happens, when they realize that I didn't realize I had to have breast cancer.
What is chemotherapy? How does it work?
Chemotherapy has been around for about 30-40 years.
Hi guys, I'm Dhruv Gupta, co-founder of Orange Health Labs, and welcome to the Orange Club podcast. Here, we'll be bringing on doctors and health experts to talk about all things that help all of us live healthier and better. Today, we have Dr. Vijay Agarwal, who is a professor and lead oncologist at Apollo Hospitals, Bangalore. He has trained in the UK and some of the top institutes across the country and has a PhD in pioneering cancer research. Welcome, doctor. Really excited to talk to you today about cancer. And to start with, and this was my question when I met you the first time is, what is medical oncology?
Sure.
You know,
Thanks, Dhruv, for having me here. It is indeed my pleasure to be here with you. In terms of medical oncology, it's a specialty of cancer treatment. So when we treat cancer, cancer is treated in a more holistic manner.
Hmm.
So not one person can treat all of it. We have different specialties such as medical oncology that deals mainly with drugs, which could be chemotherapy, immunotherapy, or targeted therapy. Then we have radiation oncology that treats with mainly radiation therapy. And nowadays we have a lot of advances in radiation therapy, which we can talk about during the course of the talk today. And then we have surgical oncology that does mainly surgical work for cancer treatment. So these are the main three pillars of oncology, and I specialize in medical oncology, which is drugs. So I deliver chemotherapy, targeted therapy, immunotherapy, and so forth.
Wonderful, wonderful.
Mm.
Thank you for sort of demystifying what that is. Cancer, seems like a sort of a death sentence when someone hears about it, right? And it's partly due to historic reasons and things like that. And you having treating patients from across the country, you would be seeing that, right? Before we get into some of the details, just broadly want to get a sense from you. What are the broad trends that you're seeing in terms of cancer patients? What are the general trends that you're seeing?
See, in terms of cancer, I mean, you're right. Historically, it has always been a death sentence because we didn't have treatments available. But over the past couple of decades, I think a lot of advances has happened more in terms of early diagnosis. So when patients are diagnosed earlier on, they're more likely to get cured from cancer. And nowadays, when we're seeing in our practice, about half of them do get cured from cancer.
Wow.
So that's a big achievement that's happened in the past 2 decades or so. When you talk about cancer trends itself, I think the population statistics are always there, and I think one can just Google it and know the incidence of cancer. But in India, the reported cancer is that about in 1 lakh population, about 100 of them will get cancer.
Okay.
It is slightly higher in the Western world. It can go up to 300 per lakh population. Uh, it just depends upon which school of thought you have. I personally feel that it's not that the cancer incidence is less in India. I just feel that it's underreported. So a lot of people do get cancer, but they don't report it. So the hospitals are not aware, or they don't present to the doctors. So there's some amount of underreporting. Whether it is 3 times, I don't know, but I suspect the actual incidence of cancer is about 1.5, 2 times of what is actually being reported. In terms of the trends, in terms of types of the tumors, I think the commonest cancers that we see in our practice are lung cancers and head and neck cancers, mainly because of tobacco, either in chewing form or smoking. And breast cancer is pretty common in our practice as well. So I think these three are top cancers that we kind of see.
Got it. Yeah, that's an interesting point that you talk about. That the risk of cancer, the presence of cancer is 3 times in Western countries
Mm,
as opposed to India, right? And do you think there's any lifestyle difference that causes this,
yeah.
or do you think this is just about reporting and actually detecting it.
So I think some amount is of it is, I think, reporting.
Hmm.
There are other factors that can kind of suggest why cancer incidence may be higher in the Western world. They live longer, so the life expectancy is longer than us.
Ah,
So the
okay.
longer you live, the more likelihood of getting cancer is there. Because, they have very robust screening programs for
Hmm.
cancers, for like breast cancers and colon cancers and cervical cancers. They have more robust screening program, so they're more likely to identify cancers much more than kind of we do.
Okay.
uh, Lifestyle causes, certainly yes, and I think it's different countries have different lifestyles. So our problem is more about smoking and alcohol, and their problem is more things like sexually transmitted disease or obesity or physical inactivity that is resulting in cancer. So the causality may be slightly different between the population, but I think the main common reasons are, of course, underreporting in India, plus them living longer and more diagnosis that happens there because of better healthcare coverage.
Got it, got it. And some of these numbers that you quoted, right? These are what you would call as national statistics, right?
Correct.
But if you look at some of the top cities of India, I mean,
Mhm.
we live lives
Mhm.
in the top metros, which are a lot like the Western world,
Mhm.
right? So do you see a high incidence? And we also live longer lives,
Mhm.
right? As India is getting wealthier, healthier, as healthcare is improving, we're starting to see people live longer
Mhm.
lives, right? So are you seeing there any difference between like urban and rural areas in this?
Yeah, possibly yes. I mean, you could look at anecdotal data, but we don't get accurate data in terms of regional, so urban versus rural divide. So that data does not exist, because in Bangalore itself we have urban Bangalore and rural Bangalore, and they all present to us. So I don't think so we'll ever get that kind of accurate data. But I think the trend is right.
Hmm.
I think if you look at so there's certain diseases that are more common in lower socioeconomic status, and there's certain diseases that are more common in higher socioeconomic status.
Okay.
For example, if you look at gynecological cancers, higher socioeconomic status is more ovarian and uterine cancers, and lower socioeconomic status is more cervical cancers. So clearly, historically, 10 years ago, we were seeing a lot more cervical than ovarian and uterine, and now it's reversed. We're seeing more ovarian and uterine cancers
Hmm.
as opposed to cervical cancers. Whether that's because of better vaccine penetration or pap smear testing, it's kind of difficult to say. But even if you look at it from the lung cancer, the squamous cell carcinomas, which are more common in lower socioeconomic status, has come down, and adenocarcinomas, which are more common in higher socioeconomic status, has gone up. So we're seeing that trend shift happening in our practice, and
Hmm.
that might mirror exactly what you're saying, is that since our lifestyle is more mimicking the Western world, the incidence or the type of cancer presentation may be going down that route.
Interesting. So, talking about some of the cancer that you talked about in women, right? Uterine,
Mm.
you talked about breast cancer being
Yeah.
what's happening with in the breast cancer space,
So breast cancer is one of the commonest cancers. It is the commonest cancer in women
Hmm.
in India, outside of head and neck cancer. Um, the good thing about breast cancer is it's external, so women can feel it. So you don't need to have a scan every now and then to kind of do proper screening program. A good clinical examination or cell breast examination is a good way of finding breast cancer, and it is cheap. It is very effective. It doesn't cost money. Every woman can do it. So it is
Hmm.
about empowering the women, giving them the knowledge that you should self breast examine yourself. And if you do that, the chances of diagnosing breast cancer earlier on is much higher.
Okay.
So currently in our practice, of particularly across India, I think more women present with advanced cancers rather than early cancers compared to the Western population, where the vast majority of them present with early cancers.
Hmm.
Now we know that the cure rate from early breast cancer is as high as 80%,
Okay.
but in advanced cancers it is less than 10%.
Wow.
So there's a kind of a big difference between them. There are cancer screening programs that kind of exist, which is like doing a mammogram once every 2 3 years and things like that. And I think as more people have better health coverage, better insurance coverage, I think these things will happen. I think a lot of insurance companies do cover health checkups as a part of their packages. So I think if more women are aware that they need to self breast examine themselves or go for mammogram once in 2 to 3 years,
Hmm.
hopefully we'll diagnose cancers a little bit earlier on, which has a much higher cure rate than later on.
Got it. Got it.
Mm,
And just digging a little bit deeper into
mm,
that, right? So, like this is a really interesting data point that you said, right? Where like if you get detected later, the risk of survival is 10% versus 80% if you get detected earlier. So let's talk about, say, men and women, just sort of keeping a sort of genetic trend. At what age, do you think it's good to start testing for things like cancer? When do you start thinking about it?
So there is no one test
Hmm.
that this is a cancer test and everybody should do it. That does not exist.
Hmm.
Okay, it is. So let's be very clear that cancer is, though the trend is increasing and we're talking about it more and it's more in the news, it is still a rare disease, thankfully. Like compared to your tuberculosis, your infections, your heart diseases, diabetes, hypertension, compared to all of that, cancer is still relatively rare. Okay, so you can't screen for all cancers. It is just not practical.
Hmm.
So I give you an example. Can we screen for for say pancreatic cancer? No, it's extremely rare, and you can't screen the pancreas every year for the whole population. It is just not practical. So there are about 3 or 4 screening programs that have been shown to be very successful. And the reason why these programs are very successful is that there's a big lag time between the disease formation and the actual presentation. And if you intervene between that period, okay, the outcomes are better.
Hmm.
So the kind of 4 screening programs that exist worldwide are your breast cancers, your colon cancers, cervical cancers, and lung cancers.
Okay.
So these 4 have established screening programs. For the vast majority of the other cancers, there is no program that exists, and I don't think screening will help you diagnose them earlier on. In fact, if anything, you might end up being over investigated and over treated.
Okay.
Okay, but these 4 of them established programs, and when you talk about age, I think there are different ages for different. So for breast cancers, the age cutoff, at least in India, what we use is 40 years.
Okay.
But for cervical cancers, it's as young as 21 years.
Wow.
Okay, for colon cancers is about 45 to 50, and similarly about 50 for lung cancers. So, but lung cancer, if you're a heavy smoker, you've got 20 pack years of smoking history. And I think once you hit 50, you really need to undergo a screening program, which is a CT scan once a year. If you have a strong family history of colon cancers, for that matter, if there's colon cancers in your family and your surrounding, your first and second degree relatives, then you might want to do a stool test once in 5 years at the very least. There are things like that exist.
Got it. So, like I said, cancer feels like this death knell, right? If you could just maybe demystify, cancer is like a very broad term also.
Mhm.
It's kind of like an infection of sorts, right? Like it's a very generic term. Now it almost seems like there's so many cancers, right? That actually each of them is a separate issue. How should someone think about it?
Sure. So basically, in our body, we have cells, right? Cells make up the tissue, and tissue make up the organ, and then the organ results into a function. Okay. So most of the cells that we have in our body are in a constant dynamic state. So they are replicating, they're dying, they're replicating, then die, and there's a very fine control in how that happens. Okay. So there are signals that inhibit the growth, and the signals that stimulate the growth when the body requires it. Sometimes this goes wrong, and there are various reasons why it might go wrong. There could be a genetic mutation that can result into cells just multiplying and not dying, or there could be some detrimental effect, external effect, that just cells just don't die, and they may not be multiplying at a rapid rate, but they refuse to die, and that can also form cancers. Okay, so basically, unregulated growth of cells. So there's no regulation that is happening. There's nothing telling them to stop growing or start dying. So when that defect happens and the cell just continues to grow, that is actually cancer. Okay. Now, when these happens, these cells have a propensity to travel from one part to the other. So they can invade the blood vessels or the lymphatic channels that drain the fluid from the organ and go to other parts of the body. And we call that metastatic cancer.
Hmm.
So when the cancer spreads from one part of the other. And the whole body, every organ has got cells. So any part of the body can get cancers. Okay, so
Got it.
you've heard of breast cancer, you've heard of lung cancer. So the cells in the lung cause lung cancers, the cells in the breast causes breast cancer, the cells in the stomach causes stomach cancer. So these are organs that causes cancer, and loosely medically we call them carcinomas. Now, and they are specific to a particular organ. Okay, there are certain cells that are present throughout the body, like your bones. It's all over the body. Your muscles, your blood vessels, your lymphatic channels. They are across the body. and they also made up of cells. And when they become cancers, we call them sarcomas. So they also type of cancer, but we slightly use a slightly different terminology to define them.
Okay.
So for fat, nerves, muscles, bones, lymphatics, blood vessels, we use the term sarcomas. And these are the two broad terms of what cancer terminologies are like. But
All right.
any you can get cancer anywhere in the body. As long as there's a cell, it can become cancerous.
So we talked a little bit about screening. We talked
Mhm.
about what cancer is, what are the
Mm,
most popular cancers. Something that everyone sort of also thinks about, right? When we hear about cancers,
mm.
what can we do to prevent it?
See, I try to divide them into three different baskets, so to speak. One is hereditary basket.
Hmm.
So you've got bad genes from your parents. There's nothing you can do about it, and the risk is higher. And you can undergo screening to identify them early, but you can't prevent them. Okay, and there are lots of genes. For example, BRCA gene is known to cause breast and ovarian cancer, and if you've inherited a BRCA gene, the likelihood of getting cancer is there. Okay, so that is kind of one basket. The other basket is the environment that you live in. Okay, so things like your pollution, if you're near a nuclear facility, or if you live near asbestos industries, you're more likely to get cancer, and that's kind of an environment. And there's probably not a lot you can do about your environment. It is for the people, our leaders, to kind of change our environment, bring in policies to clean up the system. But what you can do is the third basket, which is your lifestyle, and you could possibly modify your lifestyle to reduce the risk of cancer. Okay, the two commonest ones are clearly smoking and alcohol. Okay, and these are the two commonest causes of cancer. And I think we all know that, we all discuss that, it is there in media, is there everywhere. But barring those two, there are various other causes, not causes, but various other risk factors that increases the risk of cancer. One is obesity, reduced physical activity. Okay, nutrition plays a very very big role. So food that is high in red meat, high in salt, increases the risk of cancer. But having fruits and vegetables actually reduces the risk of cancer.
Okay.
Okay, there are other causes like breastfeeding. So longer duration of breastfeeding reduces the risk of breast cancer. Okay, infections. So there are certain infection that causes cancer. So HPV infection can cause both throat cancer as well as cervical cancer. Hepatitis can cause liver cancers. So we have vaccination against them now. So you could vaccinate yourself against hepatitis B. You could vaccinate yourself against HPV infections for cervical cancer. So those will reduce those risk of cancers. So if we factor in these things, I think we can protect ourselves to a significant extent
Hmm.
from developing cancers. Of course, there are lots of very very rare causes that people talk about it where there's no obvious causality. Things like, can my mobile phone cause cancer? Can my radio towers cause cancer? I don't know the answer for those things, but the data is kind of equivocal. But even if there's an association, it's a very very small association. I think there are more important risk factors that we got to deal with before we even talk about those things.
Got it. Yeah, I mean
Mhm.
the three big ones that I hear from you. One is smoking, the other is alcohol, and the
Alcohol,
third you said is obesity,
obesity,
right?
yes.
So smoking, of course, is an established one.
Mm.
Every cigarette pack you see this, right? And it's more to talk a little bit about some of these, right? Now, what has happened is, for example, vaping is starting to become very
Mm.
popular, right?
Mm.
Does is that better than smoking? Does from a cancer perspective?
No. So the problem with tobacco, with smoking, is the addiction. Okay, because you get addicted to tobacco, addicted to nicotine. Now, the best way to give up smoking is to get rid of the addiction. As long as the addiction is there, you will always be at a risk of increased risk of smoking and consuming tar and carcinogens and all of those things. So I don't know of any vapors who don't smoke.
Got it.
It is not a safe alternative. The safer alternative is to quit smoking
Got it. Got it.
completely.
Okay. And let's talk about alcohol now,
Mm,
right? Uh, you know, lots of lots of people who may not drink every day,
mm,
uh, maybe occasionally, right? A
mm,
couple of drinks occasionally. How bad is that for people, right? What? How do you define alcohol being bad for you from a cancer
yeah.
perspective?
So social, I think we have to differentiate between social drinking and alcoholism. They're completely different. Um, the thing about alcohol is that, or with anything, in moderation is okay, and excess is too bad. Now, the question is, what is moderation? Okay, so there's certain guidelines that exist for alcohol consumption, which is reasonably safe, which says that having one small drink for women and two small drinks for men per day is okay. The risk of cancer is quite low with that, as opposed to having multiple drinks a day. And I'm not being sexist here. It is just that alcohol dehydration enzymes is more active in men,
Hmm.
so they're allowed a slightly higher limit than women are. Um, but what causes the problem is heavily drinking every day.
Hmm.
So you're having half a bottle a day, and so that is what increases the risk of cancer, because the damage to the liver is quite significant
Got it. Got
in
it.
those situations. Any chronic irritation in the body
Hmm.
results in cancer. So
Okay.
consuming alcohol that irritates the liver on a chronic basis, you get chronic liver disease, and that kind of results in cancers. So these limits are quite arbitrary. Uh, it does not mean that you don't drink for 4 days and 5 days you can have five drinks. It doesn't work that way. But yeah, in moderation, having one or two drinks a day
Hmm.
within limits should not be a major problem. So for vast majority of the social drinkers who don't binge, you should be okay.
Understood. Understood.
Mm,
Cool. Switching to safer things, seemingly safer things. Let's say, I've one common thing I've heard is when someone gets cancer, they're asked to remove sugar from the diet
mm,
completely. Right? What's the relation between
mm.
sugar and cancer?
So there's no relation, and you don't need to remove sugar from the diet.
Okay.
That's the kind of punchline. Uh,
Wow.
when cancer is growing, it needs sugar because it's multiplying at a very rapid rate. Okay. Uh, if you remove sugar from the diet, it will take it from the body.
Okay.
Okay.
Hmm.
So the point of removing sugar from your diet is completely pointless, because the cancer knows how to take it will break down the fat cells first, then it will break down your muscle cells for next, but it will take its sugar from the body. So there is no recommendation to stop sugar completely if you've got cancer.
Got it. Got it. Got it. Wow. That's really insightful. I had no idea
Yeah,
about that.
yeah.
And so you're saying that even from a lifestyle perspective, it doesn't matter. Like every second person I come across is saying, "Oh, I'm trying to reduce my sugar. I'm off sugar."
It's a
So
very good idea to do that.
okay.
I've been trying to do it for a while now.
Mhm.
But see, removing sugar from the diet helps in being healthy. It reduces the risk of obesity, makes you more active, controls your insulin levels in the body, so your blood sugars don't fluctuate. So it makes you more active. So, like I say, obesity and lack of exercise is one of the important risk factors for causing cancer.
Mm-hmm.
So, if you reduce the risk of obesity and you're more physically active,
Yeah.
your chances of getting cancer is lower. Whether that cutting sugar helps you achieve that, why not?
Got it. Got it. Got it.
Yeah.
Okay. Now, one personal question. Okay. So, I'm a big believer in fasting, right?
Mm,
Intermittent fasting, and I've been
mm,
practicing for many years. Just because I've
mm,
seen some research saying it's broadly helpful, right? Uh, is what is there a correlation? Is one, do you have a view on fasting in general?
mm, mm.
And two, from a cancer perspective, what's the thought?
So I think fasting is good. I think there are various definitions of fasting. Some people have a daily fasting, so I fast for an X number of hours and I eat for X number of hours. Some do it, I'm going to fast for 2 days a week and then eat for the rest 5 days. So there's
Hmm.
different terminologies and depends upon where you take it. I'm not a nutritionist, so I'm not going to delve into the type of fastings. But as with I spoke about sugar, if fasting helps you maintain your body weight, maintains you be more healthy, be more active, that will certainly help reduce the incidence of cancer.
Got it. Got it. So fundamentally, it all boils down to just sort of living a broadly healthy
Healthy life.
lifestyle, maintaining a good weight,
Mm,
maintaining a balance of things
mm,
across. Just saying that okay, that like you can have alcohol if you need occasionally.
yeah.
Just like live your life, but
Within moderation.
with moderation.
Yes.
Cool. No, that I think that makes that sort of demystifies how
Mm,
complex it may be, or how actually easy it is
mm,
for us to sort of live a healthier life.
mm,
Great. And so you talked a little bit about vaccinations as well,
mm.
right? So some of the two vaccinations that you mentioned. So what are the vaccines that are now popular, or upcoming, and people should consider, and when should they consider it?
So the two commonest vaccines that can help you with cancer prevention are your hepatitis B vaccination. That you can take it at any point in time. So there's no time period of when to take the vaccine. If the moment you're aware of it, I think most healthcare professionals anyway vaccinate themselves against hepatitis B. But the general population, you can just go meet your doctor and say, I want to be vaccinated against hepatitis B. Age issue comes around when you're talking about cervical cancers. So when we're talking about cervical cancer, the ideal age to vaccinate is between 11 to 13 years of age. So girls between the age of 11 to 13. And essentially, that's come on because so what we're trying to do is we're going to try to vaccinate against HPV infection. Now you get HPV infection once you're sexually active. Okay. So the idea is that once you're sexually active, there's a possibility that you may have already developed the infection. So the idea is to vaccinate before that
Hmm.
so that you don't catch the infection and it protects you from the infection. So that's where the 11 to 13 age is kind of common. But as long as you're not sexually active and once got vaccination before that, I think you get the maximum protection. But even if you're sexually active, it does not mean that you it won't benefit you in any way. If you still don't have the infection, you might still benefit from it.
Got it, got it, got it. And this, just a little bit on the HPV side,
Mhm.
right? So this 11 to 13. So this was something that existed before also, right?
Mhm.
What has changed? Because it's just in the last, like, I would say, decade that you hear so
Mhm.
much more about the HPV vaccine.
Because we've got the vaccine now.
Okay, got it,
Yeah.
got it. All right. And so just switching gears back to, what we're talking about lifestyle, right? How does exercise help with reducing the risk of cancer?
So the it's difficult to kind of define molecularly what happens. Okay, but when we look at statistical association, people who are of lean body weight and are more active have less chances of developing cancer. And the cancers that are commonly associated with that are things like your colon cancers, your uterine cancers,
Hmm.
breast cancers. These are the three very commonly coded cancers that reduces in incidence in people who are active and healthy.
Got it, got it. And one thing that I wanted to, as we were talking about cancer, right, the incidence of cancer. So now there are even blood tests that
Mm.
actually help you detect cancer. There's CA, CA 19.9, a
Mm.
bunch of other tests that you would know more about. And let's say someone gets this test, right, and they one how frequently should you get some of these tests? Because a scan is something that's much more serious. You need to go to a doctor, you need to get that done. But now people do health checkups where, sort of every year, every 6 months, people get their health checkup done, which covers some of these things, right? So one, from a frequency perspective, how do you think about that? Two, if you do get a report which shows that you may have an elevated risk, what do you do then? So
So the first thing is that there is no routine screening for these cancers in terms of when we look at these tumor what we call them as tumor markers.
hmm,
There's no screening program that kind of exists to say that we should do these tests regularly.
okay.
Okay, particularly a CA 19-9 or CA 125. We do these tests more in terms of corroborating whether someone's got a particular cancer.
Hmm,
So they have to have some symptoms, and we have to have some suspicion that maybe if it's an ovarian cancer, then we check a CA 125. I normally don't recommend for the whole population going and checking themselves for CA 125 because you run the risk. There are other causes of raising these markers rather than just pure cancers, and you tend to kind of over investigate them.
hmm, hmm.
So that's the kind of first thing. PSA test is slightly different. I think a lot of people do PSA test, particularly above the certain age group. So if you're 75, 80 plus or 75 plus, you may want to kind of do a PSA test just to keep an eye because 1 in 3 elderly men will develop prostate cancer. So that's kind of
Wow.
one test. But for a vast majority of the other tumor markers, it's not something that I recommend routinely
Hmm,
unless you have a symptom or a suspicion of developing that cancer. If somebody comes with a report that says that this is high, then that is something that you will have to investigate. And most of these tumor markers have got kind of paired organs. So, say 19-9, you think of pancreatic cancers,
hmm.
AFP, you think of either testicular cancers or liver cancers. So, things like that. So, you kind of at least do a very basic investigation to see if it's associated with that. Now, if it's mildly raised, you don't worry so much. But if it is 5x or 10x of what it should be,
Hmm.
that is something that you have to take forward. And I think that's where you run the risk of over investigating if the masses start doing these tests.
Got it. Got it.
Mm.
And see, someone does get an elevated
Mm.
report, right? What's the next step?
So it depends upon the organ
Hmm.
that we suspect may be associated. So I'll give you an example. Let's say someone does a CA125 and they come with a report. Now, CA125 is raised in ovarian cancers. So the first thing I would do is please go and get an ultrasound scan of your ovaries. Now, if on the ultrasound scan the ovaries look healthy and they're fine, I probably won't do much. I'll just say repeat it in 6 weeks' time, and if it kind of goes down, we won't do anything about it. But if it
Hmm.
still continues to go up, then we might investigate it with a more detailed imaging, like a CT scan or something like that.
Got it. Got it. Got it.
Mm.
So we talked about screening. We talked about lifestyle. I wanted to touch upon something that you mentioned earlier, which is the hereditary risk of cancer,
Hmm.
right? And can you tell us a little bit more about that?
So about 15% of the cancers that we see in our practice are hereditary. So
Okay.
I mean, you've got it. You've got the genes from your parents and so forth. And you get an increased risk. And I think there are certain cancers that are hereditary, that can be hereditary: breast cancers, ovarian cancers, colon cancers. These are the commonest cancers that kind of can run into families. Now we have to be slightly careful about when we talk about running in families. Is that not all of these cancers, not all of the cancers that run in families are hereditary.
Hmm.
Okay, because we live in the same environment, we eat the same kind of food, we're culturally similar,
Hmm.
so we may be exposed to the same kind of risk factors that predispose us to lifestyle related cancers, and most of these cancers are also lifestyle related cancers. Okay, but when you have multiple members of the family having the same type of cancers, there's certain blood tests you can do to
Hmm.
identify these genes that commonly run in families. It just takes about 3-4 weeks to get the results,
Okay.
and you can identify genes. And then once you've identified a gene that runs in families, you can start a screening program for
Hmm.
the rest of the family members. So maybe kind of get a genetic counselor involved to make a family tree
Okay.
and say that okay, these are the people who needs to be investigated for that particular gene. And if they don't have a genetic defect, nothing to be done. But if they do have a genetic defect, then instead of doing a more relaxed screening program, we can do a more focused screening program, which is more frequent than normal population.
Understood. Understood.
Mm.
So one is regular screening first, figuring out what are the trends in your family,
Mm.
then potential regular screening once you get some of the
Correct.
genetic tests done. Anything that you can do to reduce your risk of hereditary?
Yeah, not really. So we don't have gene therapy, so you can't prevent it.
Mm.
Okay. Uh, some people do advocate organ removal to reduce the risk. So it's quite common with breast and ovarian cancer. So if you have a BRCA mutation, a lot of the women says that I don't want to live with the risk of breast cancer.
Mm.
Just remove my breast and do
Okay.
an implant, or remove the ovaries. If they are about postmenopausal, then it's like I don't need my ovaries anyway.
Mm.
So I don't want to live with the risk of developing cancer. So just remove my ovaries prophylactically.
Okay.
They are established procedures that exist for them, and they
Mm.
can be done,
Mm.
and that does reduce the risk of cancer. But it's a very personal decision whether someone wants to undergo that or just go through a regular screening program.
Yeah, and to what we discussed earlier, just generally living a healthy lifestyle might also be something that
Definitely,
can help people.
definitely, definitely.
Do you see any difference in how men and women respond to cancer treatment?
Yeah. So broadly, no. I mean, see, there's certain things that we have to keep in mind. For example, when we talk about breast cancer, we should not forget that men can also get breast cancer,
Really?
which we
Okay.
don't really think much about it. Okay, it's just that when that happens, when they realize that I didn't realize I had breast to have breast cancer, but men do have breast tissue
Okay.
underneath the nipple, and they can develop cancers. That is
Hmm.
something to keep in mind, that it's not exclusively just for females. Okay. In terms of response, I don't think so. There's much difference, but I think in terms of treatment, we do have to factor in certain side effects that come in with treatment. For example, hair loss is a major differentiating factor. Where most men are not so averse to it, but we're talking about women.
Hmm.
We do have to modify treatment. Some women say that I don't want to lose my hair. Can you give me alternative treatments that help protect my hair? So those things kind of factor in terms of how we make treatment decisions. Periods is another problem. Heavy bleeding can happen, especially when we're giving treatment, and the kind of blood counts drop. So that is something to keep in mind. A lot of women already have low hemoglobin to begin with, uh, because of their regular periods and iron deficiency and things like that. So there are certain treatment factors that we have to factor in when we're treating women as opposed to men. But in terms of responses, I don't see there's a big difference.
Got it. Got it. Got it. Switching gears a little bit towards more treatment orientation, right? and to actually your line of work specifically, right? I wanted to talk a little bit more about chemotherapy. That's also a broad area
Mm,
of work, right? And over the last couple of decades, there's been an incredible amount of progress that's been made in chemotherapy, right? In terms of it being more targeted, being more responsive,
mm,
more customized. Would love to hear from you about,
yeah.
what how does it work, what is chemotherapy, how does it work, what's the progress that we're making, what's the future looking like?
Yeah, yeah. So I think when we talk about and anti-cancer drugs and chemotherapy being one of them, chemotherapy has been around for about 30, 40 years. And I think one of the, and when we talk about historical treatment, and I think when we reflect back to, I know this person who had treatment and it was very difficult for him to have undergone chemotherapy. I think in terms of the choice of drugs, they have gone up significantly. What has really transformed how we give chemotherapy in the past 10, 15 years is the supportive medications. So medications to boost the immune system, medications to prevent patients from being sick, medications to deal with constipations. I think they have kind of exploded. So the chemotherapy has become a lot more tolerable.
Okay.
In fact, today the vast majority of our patients actually come take treatment and go to work, and they continue a normal lifestyle.
Wow.
Okay, so I think chemotherapy itself and how we support patients with supportive medications on chemotherapy have both changed significantly over the past 10, 15 years. Also, the changes that have happened in the past 20 odd years is our ability to do genetic testing. Now, what happens is that we are able to take a cancer gene and sequence it to identify defects that exist that we were not able to do it prior to 20 years ago. And we can see how is that different from a normal cell. So when I said initially, I said that there are certain defects that form that cancer cells multiply and then don't know how to die. We're now able to identify those defects, which are not there in normal cell but are there in cancer cells,
Okay.
and we have devised drugs against those defects.
Hmm.
So we are a lot more precise now, where we give drugs that acts only on those defects, so the normal cells are healthy and they are not damaged, and the cancer cells are the ones
So
that
more
kind of
targeted
die. More
treatment.
targeted treatment. The other expansion that has happened in terms of treatment is immunotherapy, where we now have drugs that stimulate the body's immune system to fight the cancer.
Hmm.
Okay, so they don't necessarily directly kill their cells, but they deal with the immune system, which can goes now and kills the cells. So I think all of these things developments have happened, and I think we are now looking at combinations of these treatments. So we combine immunotherapy with chemotherapy, immunotherapy with targeted therapy with chemotherapy to kind of get the best outcomes. The thing about targeted therapy and immunotherapy is that it doesn't benefit everyone. You have to have the target to benefit from the therapy. So what has really exploded is our diagnostics. So we do a lot of molecular testing now. Historically, when we talk about cancer diagnosis, we would take a biopsy, look at it under the microscope, and then say this has got cancer, and you treat it. But now we go a few steps further than that. We start looking at what molecular changes have happened, what gene defects we can identify, and then we advise treatment. So I think a lot has changed in the past 10 odd years.
Got it. And looking forward a little bit,
Mhm.
right? How do you think? What do you expect this treatment to evolve further over the next decade?
So I think the research keeps happening, and I think research is going at unprecedented rate now. I mean, if you look at the number of drugs that get approved by the DCGA and FDA, is kind of exponentially increasing year on year. Okay. As with more research and more funding going into research, more drugs are coming out, more drug combinations are coming out, more novel drugs are coming out. So I think going further over the next decade or so, I think a lot of newer therapies are going to come in that helps us treat our patients better, make them live better quality of life, and a lot longer. So I think times are, I wouldn't say exciting, but I think hopeful
Yeah.
that cancer patients will get better treatment and maybe make it a chronic disease rather than a life-limiting disease.
Mm. That's an
Yeah,
incredible
yeah.
perspective for us to have. Yeah. What while we're talking about therapy, right? One more thing. So one is about what you said, targeted therapy,
Mm,
immunotherapy. I've seen cancer patients who also land up exploring holistic healing.
mm,
Sort of non-Western medicine,
mm.
right? If that is a term. What's your view on that?
So I don't know. I'm not trained in those specialties, in those forms of medicine. So I probably not the right person to comment on that. On my own anecdotal evidence, I'm not sure in my mind clearly that they help in treating cancer. But do we work very very closely with Ayurveda for that matter? We
Hmm.
have very good relationship with them, and do they help us in a lot of supportive cares? There are a lot of side effects from treatment or a lot of effects from cancer that we're not able to deal with medically.
Hmm.
Things like neuropathy or things like fatigue, things like that, and they have certain treatments that do help patients. So kind of we work closely with them in things that we feel that our patients would benefit from them. I do feel that they have some role to play
Hmm.
in terms of cancer treatment, but I don't think so I'm qualified enough to say that with this particular alternative therapy you could cure cancer or uh, you could benefit significantly in terms of anti-cancer treatment.
So, as we talk about some of the misconceptions and common myths, right? I have heard that, for example, if you get a biopsy done, there's a risk of cancer spreading. Is that true?
So that is not true. So what happens is the cancer in the body spreads. That is what it does. I mean, cancer has no other business in the body but to grow, multiply, and spread. Whether we do a biopsy or we don't do a biopsy, it does not matter. So a lot of the patients who come to us, they've got a cancer in a particular place. There's already spread to other organs in the body, and they say, "Don't do a biopsy because it'll spread." It's already spread. Okay, so doing a biopsy does not particularly make the cancer spread.
Hmm.
Okay, there are certain concepts on seeding when you're taking a biopsy. Can the tumor seed through the track and things like that? They're very historical theories and perspectives, and I think they don't really hold true in today's day and age. And if there's certain types of cancers that are predisposed to seeding, we take care of it. And I think with the newer guns and the gadgets that we have in terms of taking a biopsy, that really kind of happens. But biopsy is very very important in helping us make a diagnosis.
Hmm.
So a scan just gives you an image of what is going on. It doesn't tell you the nature of it. So if I'm say give an example of breast cancer, no two breast cancers are the same.
Okay,
Okay,
that's new.
so no two women are treated the same way. So I need to find out what type of breast cancer it is. Okay. Uh, Similarly, when you're talking about lung cancers, there are different types of lung cancers and they're all treated differently. So unless I do a biopsy, I look at it under the microscope, I will not know what type of lung cancer it is. And now we spoke about molecular testing and genomic testing, and I think unless we have and those are done on the cells that we extract from biopsy. So without a biopsy, I think we will be using very primitive methods of treatment. If you are talking about modern treatment and modern modalities, I think biopsy is an absolute requirement as long as it can be done safely.
Understood.
And I
Understood.
think now lots of newer developments have happened. Now we also talk about liquid biopsies.
Hmm.
So a tissue biopsy is a tissue when we take, and that's a solid biopsy. We put a needle into the tissue and take it. Now there's a lot of thought that these tumors shed DNAs. There's the genetic material in the blood, and we can actually just take a blood sample and extract those genetic material and look at that under the and sequence that and kind of identify what type of cancer it is and things like that. But they are evolving, and I think till that kind of matures, I think biopsy will be still be the mainstay of treatment going forward.
Understood. Understood. So we talked about treatment. We talked about the future of
Mm,
treatment. The other area of concern when you think about cancer, right, is actually the cost of cancer,
mm,
right? Um, Testing, medicines, surgeries. I mean, it feels like a huge financial burden, right? Can you talk a little bit about how
yeah,
the cost of cancer treatment, testing, all this is evolving, what it's
yeah.
like, and what's the future like?
As with anything new, newer techniques, newer medicines, most of these medicines are patented medicines. You need highly skilled people to deliver these kind of treatment, and their training also costs money. So there is no doubt that when we're talking about an average treatment for something else versus cancer, the cancer treatment is quite high, and this has become a global financial burden, not just for us in India, but across the world. Fortunately, cancer treatment in India is a lot less compared to the Western world. So it's about, I think, about 20% of what the cancer treatment is in the Western world. So we are that way to a significant extent privileged that our cost of cancer treatment is quite low, thanks to a lot of the subsidies that come both from the government as well as the pharmaceutical industries. They highly subsidize our costs. So we have a lot of patient support programs for latest medicines, immunotherapy and targeted therapy. They're heavily subsidized by the pharma industry. So that way, a lot of our patients are able to afford. Nevertheless, keeping that in mind, also, I think when you look at an average GDP versus the amount one has to spend in cancer treatment, there is a big disparity. Ayushman Bharat program from the government goes a significant way in terms of bridging some of that cost, though the limit of 5 lakhs is quite less. I think the best way forward would be private insurance or corporate insurance. And I think when we look at what used to happen 10 years ago, where the insurance limits were 2 to 3 lakhs, and I think now when I see patients, most of the insurance limits have gone to about 10 to 15 lakhs. And I think in terms of cancer treatment, that's a fairly reasonable amount to kind of insurance to have. So I think things are evolving. I think more patients are able to access treatment. There's not much people can do to heavily subsidize more than what it already is being subsidized. We do have government hospitals that give treatment for free, and a lot of the surgeries can be done there. When you talk about other modalities like radiation, the equipments itself are quite expensive, so there will be some cost to treatment. However, there's a lot of philanthropy money that comes in. There's a lot of foundations that exist, and there's a lot of crowdfunding that exists for cancer treatment. We also have Chief Minister's Cancer Relief Fund and Prime Minister's Cancer Relief Fund. So there are various ways of accessing finances. And
Understood.
I think for the deserving patients, I think most healthcare professionals go the extra way to kind of support them, trying to raise funding for cancer treatment. So I think it's a very complex network. I think just to say that cancer treatment is very expensive and our people cannot afford it is not necessarily true. I think with help of funding, with help of insurance companies, with the help of government and the pharma heavily subsidizing it, I think we are reasonably privileged in terms of the cost of cancer care that we do provide in India. When we start comparing them to the Western world, there's a completely different ballgame altogether.
Wonderful,
So,
wonderful. I have to say this has been a really insightful session.
uh,
I have learned so many things. Thank you so much for your time. Really lucky that we could have you on
yeah,
on our podcast
thank
today.
you for having me, Dhruv. It's really been a pleasure. Been a pleasure.
All right.
Thank you.
Hope you guys enjoyed the podcast. If you like it, comment, subscribe, tell your friends about it. And if there are any topics that you want us to cover, just add it in the comments and we'll make sure we'll cover them in the future.